All right, thank you very much, everyone, for joining us for the NDRI webinar series today. My name's Craig Cumming. I'm from the School of Population and Global Health at UWA, and I'm going to be chairing the session today. First of all, I'd just like to acknowledge the First Nations people from around the country who are the traditional custodians of the land where we're meeting on wherever we are today, and acknowledge any First Nations people joining us during this session. We've got a really great session lined up today with three speakers who I'll introduce as the session goes on. We're looking at methamphetamine use and the relationship with the justice system, and you'll see a range of different data presented, some quantitative survey data along with a more narrative perspective, and also a look at the current evidence for treatment options for people with methamphetamine dependence. We will hear from all the presenters first, and then we'll have a joint Q&A session at the end, and you can use the Q&A function rather than the chat function to type your questions for any of the presenters. And our first speaker today is Dr. Michael Curtis. He's a research fellow with Curtin University's National Drug Research Institute. His research focuses on the intersection of illicit substance use and the criminal legal system. Michael is presenting preliminary findings from a study examining the incidence and correlates of imprisonment among a community-recruited cohort of people who use methamphetamine in Victoria, Australia. And I'll throw over to you, Michael.
Thank you very much, Craig. All right, there we go. So I would also like to start by acknowledging that we're all on unceded Aboriginal country. I'm lucky enough to live and work on land that has been cared for by the Bunurong people of the Kulin Nations, and I acknowledge their elders past and present and extend my respect to all First Nations people who are in the audience today. So approximately 200,000 people, or 1% of Australians, are estimated to have used methamphetamine in the last 12 months. And although most people who use methamphetamine will not experience any significant adverse consequences, regular methamphetamine use is associated with an increased risk of several adverse outcomes. And these include things like methamphetamine dependence, poor physical and mental health, poor health-related quality of life, and premature mortality. And as many here will be aware, drug law enforcement remains a primary policy response to methamphetamine use and attempts to reduce methamphetamine-related harms in Australia. And as a result, people who use methamphetamine are overrepresented in Australia's prisons. For example, despite approximately only 1% of the general population being estimated to have used methamphetamine in the last year, recent estimates suggest that almost half of people in prison had used methamphetamine in the year prior to their imprisonment. And for people who use methamphetamine, imprisonment is associated with adverse outcomes, including, but certainly not limited to, disconnection from their family and their community, fractured health and social support services, deteriorations in mental health, loss of employment, loss of housing, and many of these impacts extend into the post-release periods as well. And while there is research describing the overrepresentation of people who use methamphetamine who are in prison and the harms they may experience during and following imprisonment, to date, there have been no prospective Australian studies examining rates and correlates of imprisonment among community-recruited cohorts of people who use methamphetamine. Prospective studies, that is, studies which follow the same people over time, can be incredibly useful to identify factors which may predict future events such as imprisonment, thereby providing evidence to inform targeted interventions which may reduce imprisonment amongst people who use methamphetamine. Accordingly, in this study, we aim to estimate how often people who use methamphetamine are imprisoned and what factors may increase or reduce their risk of imprisonment. The data for this study came from an ongoing prospective cohort study of people who use methamphetamine in Victoria. And this study is called the VMAX study. And this is run by our collaborators at the Burnett Institute and Monash University. VMAX is run in metropolitan Melbourne, as well as 4 areas of regional Victoria. Study recruitment commenced in 2016 and has a rolling recruitment, so we continue to take some new participants to this day. And at the time of the analysis, just under 800 participants had been enrolled into the study. VMAX eligibility criteria included being at least 18 years of age at the start of the study, reporting at least monthly use of methamphetamines, primarily by non-injecting routes, so we're talking snorting, smoking, or shelving, and the ability to provide informed consent. Participation in VMAX involved a regular interview which covered topics such as demographics, drug use, criminal justice involvement, and service use. Interviews were conducted every 6 months for the first 4 years of the study and have then been annual since the start of the COVID-19 pandemic. So the outcome for this study was a binary, so yes or no response, indicating whether somebody reported being imprisoned at least once since their last VMAX interview. And we calculated imprisonment rates by dividing the number of interviews where a period of imprisonment was reported by the participant by the total time that people in the study spent participating. We then explored whether a range of demographic, substance use, treatment, and criminogenic factors were associated with subsequent imprisonment using a method called multiple event discrete time survival analysis. So that is to say, we explored whether factors we measured at one interview were associated with imprisonment at the next interview in the future. And we only included participants in this analysis who had completed a baseline and at least one follow-up interview with VMAX and who had complete outcome and covariate data. So of the 796 participants who had been recruited into VMAX, a total of 539 had completed a baseline and one follow-up interview and had complete study data and were able to be included in the analysis. And these 539 participants contributed just over 2,200 interviews or person periods of observation, equating to almost 2,000 person years of observation. At baseline, participants had an average age of 35 years, just over a third identified as either female, non-binary, or another gender, and 4 in 5 using methamphetamine at least weekly. So we found a total of 114 people had been imprisoned at least once during VMAX, and there were a total of 164 interviews, which included at least one imprisonment. And overall, this produced a crude imprisonment rate of 93 events per 1,000 person years of observation. And in multiple event discrete time survival analysis, we found that people who identified as female or other non-binary gender identities and people who were employed had a lower hazard of future imprisonment, while Aboriginal and Torres Strait Islander people who used methamphetamine at least weekly, and people who had previously been to prison as an adult had an increased hazard of future imprisonment. Residential location, so that is whether people were residing in a metropolitan Melbourne or in different areas of rurality, homelessness, injecting drug use, and recent participation in methamphetamine treatment were not associated with an increased or reduced hazard of imprisonment. So we found that 1 in 5 participants reported being imprisoned during VMAX study follow-up at a rate of 93 imprisonments per 1,000 person years. And although most VMAX participants were not imprisoned during the study, our crude imprisonment rate was almost 40 times greater than the imprisonment rate of the general Australian population. And our studies point to several areas where targeted interventions may help to reduce these high rates of imprisonment amongst people who use methamphetamine. So a previous history of imprisonment was the strongest predictor of imprisonment in this study, with people who had previously been to prison having on average an almost 4 times greater hazard of being imprisoned at their next VMAX interview compared to people who had never previously been to prison. And this suggests that sending people to prison is unlikely to address the environmental, behavioural and structural factors which contributed to their imprisonment, and that alternative responses to methamphetamine-related offending are needed. Acknowledging that for this study, we didn't know why people were actually imprisoned, In Victoria, it is possible that some people in this study were imprisoned simply for methamphetamine use or possession, as this is currently punishable by up to 1 year imprisonment. And given the growing body of research which shows that criminalisation of drug use doesn't deter drug use and can impede housing and employment opportunities, decriminalisation of drug use and possession should be considered. Further, non-custodial options, so things such as community-based orders, typically facilitate better health and recidivism outcomes than periods of imprisonment, and these responses should be prioritised for non-violent methamphetamine-related offences. And in situations where people who use methamphetamine are imprisoned, improved access to evidence-based in-prison and post-prison release supports, which facilitate timely access to safe and secure housing, training, employment, health, and other social supports are needed to try and break these cycles of re-imprisonment. We also found that weekly or more frequent methamphetamine use was associated with an increased hazard of subsequent imprisonment. And this is the part of the talk where I would normally talk through about the need for investment in evidence-based AOD treatments and what works, what doesn't work. But instead, we have someone who is far more qualified to talk to this at the end of the webinar with Rebecca McKetin talking. So I'm just going to skip this section and stay in my lane. But one thing I think that is interesting and related to this is that we found no effective recent participation in methamphetamine treatment on subsequent imprisonment. And again, I think some of Rebecca's talk about the current evidence base for treatment around what works, what doesn't, and access may help clarify this point a little bit. As with all studies, there are several limitations to this work, in particular, the fact that we weren't able to count the number of times that people were in prison during this study because of the way that the data were collected. So to wrap up, we found that 20% of people in a cohort of people who regularly used methamphetamine were imprisoned at least once during the study. Some were imprisoned multiple times. And this occurred at a rate nearly 40 times greater than the general Australian population. Initiatives which reduce recidivism and increased investment in access to evidence-based methamphetamine treatment may reduce imprisonment amongst people who use methamphetamine. I'd just like to quickly acknowledge the VMAX participants, my co-authors on this study, our colleagues at the Burnett Institute and the Monash University in the fieldwork teams, and the funders for this work and for the VMAX study more broadly, the Australian Research Council, the NHMRC, and the initial seed funders, the Colonial Foundation Trust. Thank you very much.
Thanks very much for that, Michael. Okay, so it gives me great pleasure to introduce Professor Rebecca McKetin, who, along with being an excellent PhD supervisor, speaking from personal experience, is a professor at the National Drug and Alcohol Research Centre at the University of New South Wales. Rebecca's done extensive research during her career that has improved our understanding of methamphetamine use, including the size of the problem and also the impact on a range of health and other societal outcomes. Naturally, Rebecca's work has evolved to focus on making evidence-based treatments available to assist people who experience methamphetamine dependence. And I'll throw over to you now, Rebecca.
Thanks, Craig. Thanks for the invite to come along today. It's a real pleasure to be part of this symposium. As Craig said, I really love doing research on methamphetamine and really happy to see a variety of people doing this. For a long time, I felt like the only person who wanted to do this kind of research. That's fantastic. I'd also like to acknowledge before I start that I'm on the unceded lands of the Gumbunya people over in the eastern state of New South Wales, up on the north coast. I don't know if you can see my background, but it's a very beautiful area. So today I'm going to be focusing on treatment interventions, and it kind of leverages off what Michael was saying about, well, what do we do if we want to help people to reduce their use, to reduce the risk of harms and recidivism. I just want to recap first on some of the other data that Michael alluded to. And we estimated a few years back in a Lancet paper that is a really good read if you're interested, that there's 34 million people worldwide. I think this is actually UNODC estimates that we borrowed, but anyways, about 34 million people worldwide who've ever used methamphetamine or amphetamine. And we have a very rubbery estimate that about 11% of those people who've tried the drug will go on to develop a use disorder or dependence, however you like to conceptualize that. And it's at this pointy end of the spectrum that I'm interested in my research, and where I think that there's an opportunity to intervene. By definition, if people are experiencing dependence and they're having some kind of functional impact from their use, and treatments might be appropriate in this context to help them reduce use and some of the harms they're experiencing. I think importantly, you can see here on this heat map, when you look at the concentration of methamphetamine dependence worldwide, that Australia's hitting the heat map pretty hard there, and that's why it's so important for us, and why I think we have a leadership role in this area to try and provide, develop and provide better treatments for people who use methamphetamine. The first problem we have, though, is that a lot of people who use methamphetamine who experience dependence or a use disorder, as per the DSM-5, is that they don't go to treatment. And this is not specific to methamphetamine. This is a data from a survey that the World Health Organization survey. They surveyed about 70,000 people, of whom about 1,800 had a substance use disorder, and Louisa Degenhardt published this paper to look at treatment coverage amongst those people. And what they found was only about 40% of them felt that they needed treatment. So there's a major thing there where a lot of people who are meeting this threshold that we call a disorder actually don't perceive that they want or need treatment. And then of those who did want treatment, I think it's about 60% of them had contact once at some point in their life with a treatment service. And of those, about 30% actually got what was regarded as minimally adequate treatment. And that amounted to 7% of people who met the criteria for a substance use disorder received minimally adequate treatment. I suspect if we went back to Michael, he might be able to tell you the proportion of them who end up in prison, and it's probably higher than that. You might think, well, this is 26 countries worldwide. In Australia and developed countries, it's probably higher, but actually when they looked at high income countries, it was still only 10%. So we have a real issue with treatment coverage. And then once we get people into treatment, the next challenge is providing them effective treatments. Now, if you're a treatment provider, please don't freak out at this slide. It does look like nothing works. You can see here with all the crosses, these interventions here that we love to say evidence-based actually don't significantly improve they don't reduce methamphetamine use. Before you get upset about that, just keep in mind that this is in comparison to treatment as usual in most cases. And what it's really saying is that it kind of doesn't matter so much what you do. I mean, you definitely do see pre versus post reductions in methamphetamine use with psychosocial treatment. So we know that it does help. But the problem is the effects are quite small and they don't last a long time. And what we can see is that nothing works much better than doing minimal treatment. So we're not really getting a lot of traction. As Michael alluded to earlier, one of the things that's interesting is that contingency management is one of the treatments that does appear to have a bit of grip in terms of improving abstinence from methamphetamine use. And I'll just, I hope I don't bore you too much if you know what contingency management is, but I've noticed some of my colleagues are using the term quite loosely. And in the context of using contingency management to reduce methamphetamine use or other drug use is quite specific in how it's implemented. So I want to just very quickly explain what I mean by contingency management in its most simple form, and the form that has been found to be effective, that's mainly been trialed in the USA. It's developed in the USA. Most of the work's done in the USA. It involves taking urine tests. You need some objective indicator that the person hasn't used the drug, in this case methamphetamine, and if they haven't, then they get a reward. And it's been implemented in the VA system, the Veterans Affairs system in the US, because they're a very tightly controlled treatment sector. And within that, they can get a voucher that they can spend at the commissary. And it's in addition to that, so it's not just quite as simple as paying people for not using drugs. The schedules that they use are based on behavioral therapies and operant conditioning, and it's designed to encourage people to have continuous days of abstinence. And you can see here the complexity of the reward schedule, which puts off a lot of clinicians from doing this therapy. So for the first day, they get quite a token amount of reward, might be $3. If they can come back a couple of days later and give another drug or methamphetamine negative urine, that increases. So then they get $5. On the third drug test, that goes up to 7 and then up to 10, and then they might get bonuses. But if they don't show up, that resets to 0. So there's both a carrot and a stick approach to this. And I think, yeah, so the reward schedule reset. So it's kind of a very carefully designed reward that not only provides an incentive for remaining abstinent, but also what you could say negative reinforcement for going back to using drugs. So it's designed to help people maintain abstinence. And the idea is that once they start to do that, it actually has momentum in and of itself because they've stopped using and they're starting to use this money to do positive things within their own life that they find reinforcing. So whether it's to purchase something that they want or have dinner with friends or have their family over and do other what they would call in the US pro-social behaviors. So it's kind of getting people to move on a behavioral level, and then the idea is the cognition should follow that. A cheaper and easier to implement version is Nancy Petrie's prize draw reward. So same principle, but you win draws out of a barrel, and then that might give you an opportunity. It might be a monetary prize that you win, or you might get an opportunity to win some other prize like a microwave oven or a stuffed toy, whatever you want to win. It's not something that's really taken off here in Australia at all. We haven't implemented it here, and it's because, well, there's a lot of ickiness around drug testing and the idea of this behavioural reinforcement, and clinicians don't particularly like it, and it's also quite, as you can imagine, quite cumbersome to implement. There's a lot of logistical challenges. I just want to highlight there's been some shifts though which have made it much easier to implement contingency management on the ground. This is an app that was developed in the USA called Dynamicare, and it's not the only one. There's a few of these around. This is for alcohol, but they're starting to do it for illicits as well. You can go into your phone and you do a remote test and you upload it, and the AI device recognizes that you've done the drug test and what the result is. And then you can see over here on the right, frighteningly looking a little bit like gambling, you can win money if you keep giving negative tests. So this makes the implementation easier. There's also a desktop version that clinicians can use, and that's been rolled out across California. So now it's taken up over in the US a lot more. We still haven't got this here, but I think it might transform what we can do with contingency management in Australia. Having said that, even if people do contingency management, we did some research here in Australia. Simon Clay did interviews with people who use methamphetamine to say, would you give this treatment a go if it was on offer? And this was one of the things that we found was people wouldn't really give it a go unless they had some pharmacological support. They said, I just can't stop using. Like, I'm going to get withdrawal symptoms. It's going to be really hard for me. I need some kind of substitute or some kind of pharmacological support to get through that. So with that in mind, I think if we do CM, or for that matter, any other treatments, they're not going to have much grip without having some kind of pharmacological support. I just want to very quickly show you the results of a review that I did with Shalini Arunagiri from Turning Point. We were invited by the British Association of Psychopharmacotherapies to update their clinical guidelines for stimulant use, which was very exciting. And so I want to show you just very quickly the outcomes of that against an evidence chart. This is like based on Cochrane grade evidence. And what we did was grade the certainty of the evidence as high. So it does what it does on the label. Moderate probably does what it should says on the label. Low, we're not really sure. And very low, we really don't know. And then green is benefit. yellow is no effect and red is harmful. Thankfully, we didn't find anything with red. But in summary, the guts of this, which hasn't been published yet, is that mirtazapine, there's actually fairly good evidence that it probably works, but it probably has a small benefit. Bupropion alone also had a small benefit, but the evidence was less clear. Prescription stimulants like lisdexamfetamine and other high-dose methylphenidate in particular was on the fence. It's really a small effect, and it's a little unclear whether there's some benefit there or there's not any benefit there. So we're uncertain about that. What we do know now is there's pretty good evidence that modafinil probably doesn't work, which is a bit disappointing. And the evidence on standalone naltrexone, the opioid antagonist, is really all over the shop and suggests it might not work, but we're not sure. In addition, so overall, we're finding more evidence, but that most things have a small benefit. There are a few other things I'm not mentioning today, one-off trials that have been quite exciting and things in the pipeline. So there's more things to come. However, I think at the moment what we can say is that there are these pharmacotherapies out there that may have some benefit, but it's probably a small benefit. In my mind, one of the biggest benefits, and we've just finished running a trial of mirtazapine, is that when you offer medication, you get people into treatment who haven't been to seek conventional drug treatment before. So around about half the people in our trial had never sought treatment from a drug and alcohol centre before. And this broader group of people, if you think back to that first slide, it's those people who might not think that they need treatment in the rehab sense or the detox sense, but they're happy to have a go at pharmacotherapy. They generally have less disadvantage, more likely to be employed, and a little bit higher functioning in terms of their quality of life and so forth. So we're capturing a broader group of people. I think the other thing kind of related to that is once you get people in the door, while we might not have great effective treatments at the moment for methamphetamine dependence per se, there's so much more you can do with people. When you're working with these people every day, it's quite frustrating that people focus only on the substance use. It's like when they come in, they have so many other things that you can manage and that need to be managed. Not only are there these other psychosocial supports that can help them through managing their meth use, but a lot of them have comorbid depression, and we know that CBT works for comorbid depression. There's suicide risk that you can deal with by managing that with psychosocial therapies and other interventions as well. There's medication for other psychoses and other mental health disorders, mental disorders that they have. And then people, if they're using opioids as well, we can provide them with a take-home naloxone. There are treatments for hepatitis C, which is endemic amongst people who inject. There's PrEP for HIV. And then really at the forefront of my mind is the social welfare stuff. A lot of people are coming in the door with domestic violence issues going on. They've got housing issues and financial issues and unemployment and the criminal justice stuff, all of which needs to be dealt with. So even if we can't directly reduce methamphetamine use, I think there's so much more that we can do. And we just need to remember that these are people and there's a lot that we can do to help them. Thank you.
Thank you very much for that, Rebecca. That was a great overview of what we currently know around methamphetamine treatments that are available, and the potential for using more of a public health framework for treating a range of issues that may not necessarily be specific health issues, but also social issues. And I see Shelley's rejoined us. Shelley, are you ready to go? I think you might be on mute there, Shelley.
Can you just see my slide?
I can just see a slide now.
Apologies, everyone. I'm really sorry. Yes, okay. I'd like to acknowledge the Wurundjeri people as the traditional custodians of the stolen land I'm on today and pay my respects to elders past, present, and extend that to all First Nations people in the webinar. And just to acknowledge Stacey, who's a Bunurong woman who produced this beautiful artwork for the Burnett Reconciliation Action Plan. I'd like to acknowledge my co-authors and the participants who participated in qualitative interviews who bravely and openly shared their stories with us. So as Michael has highlighted, although rates of methamphetamine use have remained relatively low but stable, the amount and frequency people are using has increased, as have the harms. Rebecca's also spoken about this. But despite lots of evidence that punitive drug laws don't deter use, methamphetamine use remains heavily criminalised, with law enforcement and punishment prioritised over harm reduction, treatment and care. So we used a social harm lens to understand how criminalisation shapes the daily lives of people who smoke methamphetamine, including impacts on their health and wellbeing. Going too fast. Participants were purposely recruited from the VMAX study that Michael talked about. Eligibility included those with a history of prison or juvenile detention and or arrest, and we only included participants who'd never injected drugs. So I'll provide a really brief overview of the participants, or the participant characteristics and their drug use, and then I'll share some of the key findings. Just to note that quotes have been de-identified and names have been replaced with pseudonyms. So 2/3 of the participants were from rural Victoria and the rest were from Melbourne. 4 identified as Aboriginal. Most had experiences of socioeconomic disadvantage. More than 1/3 had been in prison or juvenile detention, and most had served at least one community sentence. The time of qualitative interviews, around 2/3 were currently using, including 14 who were using daily. And of the remainder, most had stopped more than 6 months ago, including a handful who hadn't used for more than 5 years. When asked what it was about methamphetamine they liked, many said it was the adrenaline rush, productivity boost, or the confidence that it gave them. Many said it helped them cope with mental health issues, past traumas, or ADHD symptoms. And a few who'd been truck drivers said they'd used it to stay awake while driving. So pretty much all of the participants in this study had continued to use methamphetamine to manage some kind of health and or social issue rather than for recreational purposes of seeking a high. And this is a sentiment that's captured here by Tom, who said, no one wakes up and goes, I want to do drugs today. There's obviously underlying issues and reasons. On the flip side of this, however, most people spoke about methamphetamine in extremely negative terms, describing it as destructive, putrid and hard to escape rather than pleasurable. For example, Bobby said it's a horrible drug. It just takes everything away from you. You know, all your possessions, your family, you lose your family, you lose your partners, you lose your children, you lose everything. And Dana, who was using daily and talked about desperate. She was desperately wanting to stop her use. She said, it's putrid. I hate it. I don't like that it does what it does because blocking out everything I'm trying to block out. I shouldn't be doing that. I've got to deal with it. I wished I'd never touched it. It's not even about the high anymore. It's just to feel normal. But it's wrecked everything, family, work, everything. Because methamphetamine use was treated as a criminal issue, participants felt instantly judged, assumed to be doing something wrong or lying. Many described being watched in supermarkets, refused entry. Some described being refused entry to public toilets or confronted in public spaces. And some described deliberately staying home to protect themselves from this kind of humiliation. But the flip side of that as a survival strategy was negative mental health costs, such as feelings of isolation and depression, which could then lead them back to the very thing they were trying to avoid, which was methamphetamine use. Sarah, for example, said it can be very isolating and lonely. It's so much easier sometimes just to go back to the scene where you know it, it's comfortable. The way the media links methamphetamine use with violence and crime also shaped how people were seen by others. Many felt viewed as dangerous or dishonest, which brought shame and humiliation. And Jason here said the stigma around it and people just look, pointing fingers, you're frowned upon. You've only got to look at a post on Facebook, some misdemeanor offence or something, and you know you get umpteen comments, oh, fucking crackhead this, crackhead that, blah, blah, blah. Like you can be a good person and still be an addict. Once labelled as someone who used methamphetamine, police attention also became a part of people's daily lives. Participants said police, often knew their car, where they lived, and who their friends were, leaving them feeling constantly watched and stopped, searched or tested, even when they weren't using. Nick, for example, said how his very first possession charge set in motion sorry, I'm just having a little, the first time he was pulled over was possession, and he said that first time pulled over, they found it on me, and from that point on, it was like I was a target. So anytime they saw my car, they'd pull me over and search me. And Janie, whose only drug charges had ever been for possession, explained how she felt harassed by police years after she'd stopped using. She said, I've only ever had drug possession charges. There's never been any selling. I've never stolen anything to feed my drug habit. I had money saved, so it wasn't like I was involved in criminal activity. So all my police record shows is using drugs, but that police record still to this day gets me pulled over by the police and drug tested. Together, experiences of stigma, surveillance and arrest kept participants locked in an ongoing cycle of harm, and once criminalised, many found it almost impossible to escape. Community sentences, which are usually positioned as rehabilitative alternatives to prison, and mostly consisted of regular urine testing, community work and drug counselling, were described as degrading, pointless and often counterproductive. Some shared the frustration of having to complete community work hours with other people who use methamphetamine, which set them up for continued drug use rather than providing the genuine support or skills development that it could have. Cy, for example, who was on a community order, said after prison, he was doing his community hours. He said, everyone in jail was saying to me, you're set up to fail. And I was like, no, it'll be good, because I was off the drugs when I got out. And corrections is what got me back in it. I was at corrections, and the people that were around me were talking about it, and they were like, do you want to get some at lunchtime? And so, yeah, that's what ended up happening. And although a couple of participants said compulsory drug counselling had been really helpful and had helped them stop using, most said the experience was pointless, like Dana, who said, what I'll say is anything compulsory is a waste of time, because nobody's going to get off meth unless they want to. Nobody's going to get off meth if they're forced to do it. That's the bottom line. You're wasting everyone's time. And of the 14 participants who were currently using, most said they wanted to stop but were unable to. Many had stopped previously, including some who'd stopped because they were in prison or on community orders, but most said they found the system stacked against them. For example, Darren, who was hospitalised after a car accident and was forced to detox in hospital, said, when I was in hospital, as soon as the doctor worked out I was a drug user, I reckon he would basically have just quite happily left me to die. Others who tried to access drug treatment programs, including residential rehab programs, described being turned away or placed on waiting lists, which was frustrating and disappointing, given there was no guarantee they'd be ready again to stop by the time a bed and detox unit or rehab facility was available. Aaron said, I tried to go to rehab, but they told me it's nearly a 2-year wait. He said he felt like he was better off trying to do it himself. And some said they wished there was a replacement drug they could access, comparing what they knew about methadone for people with opioid dependencies. For example, Brad said, they've got methadone for heroin. Why can't there be something like that for ice? You can't just stop. It's not that easy. These narratives highlight that a lack of motivation to stop wasn't really the problem. Rather, it was a lack of opportunity, understanding, and a supportive environment that was free from stigma and criminalising impacts. And I think what these accounts illustrate is that criminalisation doesn't deter methamphetamine use, but rather it deepens harm, creates stigma, fractures trust, and erodes the very conditions required for change. And I think these voices are really a really powerful reminder for us that the policy logic of criminalisation is misplaced. That is, that the harm lies not only in the drug itself, but in how the system responds to it. And I think if we want to reduce methamphetamine-related harms, we need systems that are available when people ask for help, that aren't conditional on abstinence or criminal involvement, and that treat distress as something to respond to, not punish. which means shifting our focus from suspicion to care and rebuilding health and social systems people can actually use when they're ready.